You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for July 26, 2019. This week, cardiac resynchronization therapy, or CRT, ezetimibe, the challenge of future doctors, the crisis in end-of-life care, and diabetes. First up is CRT. One of the easiest calls in all of cardiology is CRT therapy in patients who have heart failure and a typical wide left bundle branch block. These patients do great. But CRT also includes one of the toughest calls in cardiology, and this occurs when a patient has systolic heart failure and a prolonged QRS, but no left bundle branch block. Remember, CRT, or biventricular pacing, only does one thing. It pre-excites the lateral left ventricular wall, and when the left ventricular wall is delayed, this equalizes or resynchronizes the right and left ventricle. If the LV is not delayed relative to the right, then putting in an LV lead will not help. And guidelines on CRT are unanimous for left bundle branch block patients, but vary a lot for patients with non-left bundle branch block. And the tension here relates to the inclusion criteria versus the actual enrolled patients that were in the CRT trials. Left bundle branch block was not a criteria for inclusion of any CRT trial, but most patients enrolled in CRT trials had a left bundle branch block. So the recommendations for CRT in patients who don't have a left bundle or non-left bundle had to come from sub-analyses of the trials. And that's usually fraught with problems, mostly based on methodologic grounds. So a recent observational study from authors at the University of California, San Diego, sought to sort out CRT effects in patients with non-left bundle branch block. And these authors separated this into nonspecific IVCDs and right bundle branch block morphologies. Now, they used the NCDR registry between 2010 and 2013. That gave them data on the implant and patient characteristics. They then linked that data with Medicare inpatient fee-for-service claims, which then gives them data on outcomes. They asked two questions. First was to look at CRT-eligible patients with non-left bundle branch block and see if outcomes differed between CRT-D and standard ICD placement. And the second question was to look specifically at CRT-D implanted patients and see whether outcomes differed in those with a nonspecific IVCD versus a right bundle branch block. So first, in the CRT-eligible group, they had about 11,000 Medicare-aged patients. The authors found that after adjustment, and remember, adjustment is necessary because this was not a randomized comparison, patients with right bundle branch block did not have better outcomes with CRT over ICD, regardless of the duration of the QRS, whether it was less than 150 or greater than 150. Patients with nonspecific IVCD did do better with CRT, but only if the QRS duration was greater than 150. So in their second analysis, the sub-analysis, in which the authors compared nonspecific IVCD versus right bundle branch block subgroups in patients who actually had the CRT-D implanted, the nonspecific IVCD had worse outcomes than right bundle when the QRS was less than 150, but the nonspecific IVCD patients fared better than right bundle when the QRS was longer than 150 milliseconds. So if you take these data at face value, it suggests that CRT in patients without left bundle branch block may be worth doing when the QRS is greater than 150 and not right bundle branch block. This data challenged some guideline recommendations which give CRT in non-left bundle branch block and QRS of just over 120 milliseconds a 2A or 2B recommendation. In this study, nonspecific IVCD did better than right bundle branch block, but only if the QRS was greater than 150. Now, obviously, this is observational data, but it does support the non-benefit of CRT in non-left bundle branch block when the QRS is less than 150. It also supports non-benefit of CRT in patients with right bundle branch block. But we sort of knew that. Other factors in CRT response include the degree of scar, the PR interval, and where the lead is placed. The authors write that an ongoing RCT looking at CRT in non-left bundle branch block patients is ongoing, and this is going to be a really good thing. We need this data. Remember, while adding an LV lead does not add much incremental risk in someone you've already decided that you're going to do an ICD in, for patients you would not operate on, unless you think they would improve with the CRT, we will just have to accept a degree of uncertainty on whether patients will respond. What I wish we had was a way to know the actual delay of the left ventricular lateral wall. Remember, QRS duration and morphology are just imperfect surrogate markers of late LV activation. Next topic is ezetimibe simvastatin combination in the elderly. Now the top-line results, the abstract in JAMA Cardiology, and the news article proclaim that the secondary analysis of the IMPROVE-IT trial showed that the combination of simvastatin and ezetimibe was safe and effective in the elderly. I highlight this topic because reducing cardiac events in the elderly is an important topic, and one in which there is a little data. That's because most lipid-lowering trials have small numbers of elderly patients. The post-hoc but pre-specified sub-analysis looked at 2,800 of the 18,000 patients enrolled in the IMPROVE-IT trial who were greater than 75 years old. Recall that IMPROVE-IT was an RCT of simvastatin-ezetimibe combination versus simvastatin alone in patients after myocardial infarction. In the original trial, the absolute risk reduction of a composite outcome was a mere 2%. The upper bound of the confidence interval hit 0.99, and there was no difference in mortality or CV mortality in IMPROVE-IT. Recall also that IMPROVE-IT was a classic case of a strawman comparator because the control arm used 40 milligrams of simvastatin, which is far from the potency of a torvastatin 80 or rosuvastatin. The post-hoc study in JAMA Cardiology broke down the primary endpoint outcomes based on the three tertiles of age: less than 65, 65 to 74, and greater than 75. The authors found that the absolute risk reduction for the primary endpoint for the less than 65 and the 65 to 74 age group was less than 1%, but nearly 8%, a whopping 8% in the elderly. The authors even wrote in the paper that the NNT is 11 for patients aged greater than 75. They noted that there were no significant safety events. Now, there's some big-name authors on this paper. JAMA Cardiology is highly respected, and what I'm going to say is not personal, but this sub-study is problematic. IMPROVE-IT did not enroll 18,000 patients for the fun of it. They enrolled that many patients because event rates are low and power calculations had it that it would take that many people to show a difference in events for the overall population. And the effect size of the combination drug against a super weak comparator barely met significance in a composite endpoint and had no mortality effects. Now, the authors want to make conclusions from a very small subgroup, just 15% of the total cohort. If 18,000 patients was barely enough in the main trial to show benefit, how is 15% of 18,000 even close to enough to find signal from noise? What's more, age is a continuous variable. Nothing magical happens between age 74 and 75 other than the author's decision beforehand to break it down that way. I'm open-minded to treating the elderly with secondary prevention meds, but these patients are more vulnerable to pill burden. I think before we put anything in a guideline or make firm recommendations about adding ezetimibe, gosh, we need more than dichotomized subgroup data of barely positive trials. Third topic is risk modification in young adults. Now, a pooled analysis of data from 6 cohort studies which span the life course of individuals yielded expected but sobering results. Multiple authors publishing in JACC analyzed trajectories of cardiac events over a median follow-up of 17 years. This study included many thousands of events and it calculated time-weighted average exposures of risk factors, such as LDL greater than 100 and blood pressure greater than 30 when people were in their young adulthood, aged 18 to 39. The unsurprising part of this analysis was that young adults with LDL greater than 100, compared with those with LDLs less than 100, had an association of 64% increased risk for coronary heart disease events, and that was independent of later adult exposures. Also unsurprising was that young adults with systolic blood pressure greater than 130 compared with those with blood pressure less than 120 had a 37% increased risk for heart failure. But the sobering part of this data is that it highlights the challenge for the next generation. While the technology of caring for the sick reaches stunning heights, lifespans have not budged and may in fact be getting worse. But even worse than decreased longevity is the increase in morbidity that comes with lifestyle-related diseases. I mean, the rise of non-communicable diseases will be the challenge of the next generation of caregivers. Of course, our urge now is to medicate abnormal surrogate markers like LDL and blood pressure. But I'm almost certain that medications will not be the answer. When I see younger patients with elevated risk factors now from, say, eating too much and moving too little, I often cite Mickey Mantle, who once said that if he knew he was going to live this long, he would have taken better care of himself when he was younger. Next topic is the crisis in end-of-life care. A few years ago, a prominent and beloved surgeon at our hospital learned he had pancreatic cancer. He did not flinch. He quit practice the next day. He did not take chemo. He went on hospice, and he died with minimal suffering. This is rare. Almost every day in the hospital, I see futile care at end of life, people suffering. Nobody wants suffering at end of life. Patients don't want it, and doctors and nurses surely don't want to deliver futile care. And one simple answer might be more education. Let's just teach people. We could teach patients that death is expected and that many of the things we do at end of life do not help. Then maybe we could have more people die like our surgeon. But as often the case, simple answers don't work. JAMA Network Open has published a provocative observational study from Canadian-led researchers on end-of-life care that is received by physicians compared with non-physicians. The theory would be that docs, knowing what they know, would choose less aggressive care. They're educated. The authors used cohort data over a 10-year period from 2004 to 2014. This included more than 2,500 docs who died and almost 1 million non-doctors. The primary endpoint of this study was location of death. And for physicians, the risk of death at home was no different than for non-physicians. But the risk of death in an intensive care unit was actually increased by a few percent. Docs were slightly more likely to receive palliative care. And this data aligns well with a 2016 observational study on how U.S. doctors die. This from Dr. Dan Mallock and colleagues, and I'll reference it in the notes. In a similarly large study, Mallock et al. Found inpatient utilization and death in the hospital was also no different for physicians versus non-physicians. And in their study also, doctors were more likely to receive hospice care. And another nugget I learned while researching these studies was that in survey studies, doctors often prefer less aggressive care. But of course, surveys of people in good health hardly substitute for what actually happens when death is near. Okay, the take-homes of this really important study, and I'm glad that it's in JAMA, and I'm glad that we covered it, are: 1, procedures are easy. Dealing with death is hard. Doctors are human too. When we're sick, we too see the right tail of the bell curve rather than the middle. 3rd, education about end of life isn't all that will be needed to reduce suffering. 4, I'm going to be a lot more humble about thinking I would make the same decision as our beloved surgeon did when he was diagnosed. 5th topic is a feature piece that we have about cardiologists expanding into diabetes care. I listened to Dr. Ann Peters from the University of Southern California discuss the ACC decision pathway on reducing cardiovascular risk in patients who have type 2 diabetes. What piqued my interest here is how little I talk about diabetes care on the podcast. And that's weird because I see a lot of patients with diabetes. Maybe it's because in our medical community we have a number of diabetes doctors, so there hasn't been a real need for cardiologists to think too much about treating this disease. My contribution to type 2 diabetes care has mostly been the cheerlead for lifestyle interventions. But with the advent of 2 classes of drugs shown to reduce outcomes in diabetes, the sodium glucose cotransporter 2 inhibitors empagliflozin and canagliflozin, and the glucagon-like peptide 1 receptor agonist, I sense a breaking of the silos between cardiology and diabetes care. Dr. Peters' column and the ACC decision pathway are clearly spoken and written. Both are worth a look, and I'll reference them in the notes. Yes, I think it's time I get more familiar with this branch of medicine. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And if you like this podcast, please tell a friend. Consider subscribing and giving us a review. That way others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.